Good afternoon, everyone. Continuing with the topic of fluid and hemodynamic derangements, today's topic is embolism. The definition of embolism is process of obstruction of the cardiovascular system by any mass carried in the circulation. Embolus is the name given to the transported intravascular mass. It can be solid, liquid, or gas, detached from its site of origin. This is the most important point to be noted is detached from the site of origin. 90% of the emboli arise from thrombus, so they are called as thromboemboli. They arise from the thrombi or their parts detached from the vessel wall. The classification of the emboli, depending upon the content, we have solid, liquid, and gaseous. Solid, the examples are from the thrombi, atheromatous material from a ruptured atheromatous plaque, tumor cells, bacterial clumps, parasites, foreign bodies, tissue fragments, as in case of a accident. Examples for liquid emboli, fat globules, amniotic fluid, bone marrow. Example for gaseous embolism, air, other gases. Depending upon the source, the classification is cardiac, commonly arising from the left side of the heart, from the atrial appendages, infarct in a left ventricle, or vegetations in case of a endocarditis. Arising from the arterioles, systemic arteries in the brain, kidney, spleen, small intestine. Venous from the pulmonary vessels or the deep veins of the leg. Lymphatic emboli can also occur. They can also be classified into septic or bland, depending upon whether they are infected or not. Paradoxical emboli are very rare. They go from the arterial side to the venous side or vice versa through septal defects in the heart. When there are defects in the heart or patent foramen ovale or arteriovenous shunts. Retrograde embolism is much rarer. It goes to the opposite to the flow of the blood. For example, carcinoma prostate metastasis to the spine. First, we will take up the most common cause for thromboembolism. Arterial or systemic thromboembolism arising from the heart, from the mural thrombi, vegetations, from the valves, or in cases of cardiomyopathy. Coming to the arteries, ruptured atheromatous plaques, or thrombi from the aortic aneurysms, or from the pulmonary veins. What are the effects of the emboli? They cause infarction, that is the necrosis due to lack of blood supply. Typical example is myocardial infarction, what is known as the cardiac arrest. Infarction of the brain leading to the stroke or paralysis. Infarction of kidney, spleen. Gangrene, large areas of infarction involving a whole limb or a whole part of the intestine. Other examples, arteritis and mycotic aneurysm, as in case of bacterial endocarditis, and it can be a cause of sudden death. Pulmonary embolism can be a cause of sudden death in individuals. Venous thromboembolism, much more common. They arise from the deep veins of the lower limbs, like the popliteal vein or the iliac veins. So the pelvic veins, other veins which are involved are the pelvic veins, upper limb veins, cavernous sinus in the brain, and thrombi in the right side of the heart. The most significant effect is obstruction of pulmonary arterial circulation leading to sudden death. Infarction of the lung, car pulmonale, a chronic condition where the lung is damaged due to increased pulmonary blood pressure and also decreased blood supply, and pulmonary hypertension. This is a picture showing a fatal pulmonary embolism. A person died suddenly, and when an autopsy was done, they found a big snake-like thrombus in the major pulmonary blood vessel, causing pulmonary infarction. This is a microscopic picture of a pulmonary embolism. On the left side, you can make out the alveoli, so we can identify it as a lung. And on the right, we can see the blood vessel. And you can see the blood vessel, the lumen is almost 90% completely blocked by a embolus. And the surrounding area, what you see as a pink homogeneous mass is infarction. So there is almost total stoppage of blood supply, leading to infarction of the area supplied by this blood vessel. Pulmonary thromboembolism, one of the most common causes for sudden death. Occlusion of the pulmonary arterial tree by thromboemboli. 90%, 95% arise from the large veins of the lower limbs, iliac, femoral, popliteal. Other sources are varicosities of superficial veins of the legs, periprostatic, periovarian, uterine, and broad ligament veins. It is common in hospitalized and bedridden people. For example, people with fracture of the hip, fracture of the femur, or people with stroke who are bedridden for months together. They have a risk of this embolism. The thrombus get detached from these sides and go to the right side of the heart. Then from the right side of the heart, it is carried by the blood flow to the lung. If large, impacted at bifurcation of main pulmonary artery, it is called as the saddle embolus. That is the picture what I showed you. Commonly, multiple fragments or small emboli to many vessels, especially those of the lower lobes. This is the gross and the microscopic picture of a pulmonary thromboembolism, which was fatal. As you see, autopsy has been done, and you can see a embolus sitting at the bifurcation of the pulmonary vessel, the pulmonary artery. There is a microscopic picture on the right side showing almost 90% of occlusion of the lumen by the embolus. The consequences are sudden death, acute carpulmonary leading to acute right-sided heart failure, pulmonary infarction, pulmonary hemorrhage, pulmonary hypertension, increase in the pressure in the pulmonary vessels leading to what is known as chronic carpulmonary. Fat embolism. Obstruction of arterioles and capillaries by fat globules. The examples are traumatic. Typical most common cause is fracture of the long bones or post-orthopedic surgical procedures, laceration of adipose tissue, postpartum. Non-traumatic in case of burns, diabetes mellitus, pancreatitis, sickle cell anemia, fatty liver. So the theories which are proposed as pathogenesis are mechanical due to trauma causing infarction, or emulsion instability, intravascular coagulation, and toxic injury. So these are the different theories which have been put forward for the pathogenesis of fat embolism. Pulmonary fat embolism, fat globules and capillaries of patients with long bone fractures. So in lungs, the picture we see is hyperemia, that is congestion, edema, small minute hemorrhages, petechial hemorrhages, and changes of acute adult respiratory distress syndrome. This is a condition where even if oxygen is given, there is no response. There will be formation of membranes in the alveoli, so gas exchange will not take place. We cannot demonstrate the fact with the routine hematoxylin and eosin sections because when we process the tissue, the fat get dissolved in the alcohol and other solutions we use for processing. So when we have a suspicion, we have to do frozen section using cryostat or a freezing microtome and stain with special stains such as Sudan black, Sudan 3 or Sudan 4, oil red O, and osmic acid. So this is a picture what we see in a hematoxylin and eosin stain. The inside the blood vessel, you see some empty areas, vacuoles, that is suspected to be fat. But we can tell only with confidence after doing a special stain like this, Sudan black. Systemic fat embolism. Fat globules pass through the patent foramen ovale, arteriovenous shunts in lungs and vertebral venous plexus, goes to capillaries of brain, kidneys, and skin. So in brain, small hemorrhages, microinfarcts, and edema leading to delirium, convulsions, coma, and even death. When it goes to the kidney, it decreases the glomerular filtration rate, causing tubular damage. Petechiae in skin and conjunctiva and serosa is also seen.